Hello and welcome. This is NTA Tuesday Live and I'm Cyril Stober. Glaucoma, a disease that damages the optic nerve, represents a major cause of vision loss throughout the world. Now this is more worrisome, going by global statistics of about 314 million people being visually impaired, out of which 45 million are blind, and with 87% of the visually impaired living in the developing countries. So as the world focuses on Glaucoma Week, observed from the 12th to the 16th of March, how much awareness is created on early detection, treatment, and possible surgery before long-term visual loss happens? Is it preventable or even curable? Who are mostly at risk? And what's in place to achieve global target of the WHO in Vision 2020 to reduce blindness prevalence to less than 0.5% in all countries, or less than 1% in any community? Now, these are the issues we'll be raising tonight on Tuesday Live. But first, let's get to see this report by Rabi Abdallah.
Glaucoma is a disease of the eye that damages the optic nerve, that is, the part of the eye that carries the images we see to our brain. In the healthy eye, a clear liquid circulates in the front portion of the eye. To maintain a constant, healthy eye pressure, the eye continually produces a small amount of this fluid and an equal amount which flows out of the eye. If a person has glaucoma, the fluid does not flow properly through the drainage system. Although there are four main types of glaucoma, comprising chronic glaucoma, acute glaucoma, secondary and developmental glaucoma. The most common is chronic glaucoma, in which the eye fluid can get to the drainage channels but slowly become blocked as time goes on. The eye pressure rises very slowly and there is no pain to show there is a problem, but the field of vision gradually becomes impaired. Age, race and family are factors which increase the risk of glaucoma, with people over age 60 mostly at risk. Others are family history of the disease and individuals of African and Hispanic ethnicity. People with a high degree of short sight are more prone to chronic glaucoma, while diabetes is believed to increase the risk of developing the condition. Data from the Nigeria Blindness Survey places glaucoma as the leading cause of irreversible blindness worldwide, accounting for 8% of all blindness, affecting an estimated 3.12 million blind people. Statistics from the last national survey indicate that about 114 million adults in Nigeria have glaucoma, most of whom are not aware that they have the disease, while 1 in every 20 Nigerians aged 40 years and above have glaucoma, and 1 in 5 being blind. The survey on the population of glaucoma patients also showed that Southeast has the highest prevalence of glaucoma blindness in the country. Acute glaucoma is treated with drugs and eye drops and may be followed by laser treatment or surgery. To quote the experts, early detection is key to slowing progression of glaucoma, and regular eye tests are the only way to detect glaucoma early. Public health control strategies and high-quality glaucoma care service will be required to reduce morbidity and blindness from glaucoma. I am Rabi Abdallah.
All right, that report by Rabi Abdallah sets the tone for tonight's discussion. Let me introduce our guests to you just before we start off. All of them professionals dealing with the eyes. Yeah, so let's start from Dr. Ibrahim Khanna, who's consultant ophthalmologist in the Federal Ministry of Health. Thanks for being here.
Thank you very much, sir. Good evening.
Okay. Let me also welcome to this program Dr. Mahmoud Al-Hassan, Chief Medical Director, National Eye Center, Kaduna. Thanks for being here with us.
Thank you so much. Happy to be here.
Right. I'd also like to welcome to this program Dr. Ngozi Wanikeze, an optometrist and fellow of the Nigerian College of Optometrists. Thanks for being here.
Thank you.
And we're also joined tonight by Dr. Kola Gundimu of Sight Savers. Thanks for being here.
Thank you very much.
Right, as we always do at the start of this program, we acquaint you with the procedure. At the appropriate time, you can get to join in the discussion in the studio. The various platforms will be on your screen. You can take advantage of them. However, for those who will be calling in, we say this every week. When your call gets passed through to the studio, do us a favor. Turn down the volume of your TV set. Just reduce the volume. And this is so we can avoid the hurlback or echo. And the best way to know your call has been passed through is to watch the screen and see once your name appears on screen, it means that your call has been passed through. You see your name on screen, you just go right ahead with your question or comment. Don't bother too much about the greetings. And I would like to encourage you to keep it short, straight to the point, and so others can get on this platform and be part of the program. So once again, welcome to Tuesday Live, and it's a very important topic tonight. Let's start by finding out how this disease can be managed, what causes it, and if there is a cure. Let's start off with Dr. Ibrahim Kana, glaucoma.
Well, glaucoma is actually one of the eye conditions or diseases that actually affects the optic nerve. The optic nerve actually is the nerve that connects the eye to the brain, which is responsible for sight. And what happens in glaucoma is that the disease actually causes the damage to that nerve, and gradually the patient begins to lose vision. The dangerous thing about glaucoma is that as the vision is being lost, the patient usually does not know. And that's why we say it steals the vision quietly. And it is more worrisome because as the patient doesn't know, the vision continues to get lost because of the glaucoma, either as a result of high pressure or sometimes even normal tension in the glaucoma. In some patients. At the end of the day, the patient will come down with blindness, and that is the most dangerous aspect of it. And the worst part of it also is that any nerve that is already damaged cannot be reversed again. And that's why we encourage early diagnosis, and one must always be checking his eyes regularly.
So the damage is permanent, irreversible?
Absolutely.
Blindness?
Absolutely. Unfortunately so.
All right, we'll return to you, but let's hear from Dr. Hassan.
Thank you very much. As just some additional information, glaucoma is the leading cause of irreversible blindness, and the lost vision cannot be restored. And I think that is the primary information. Unfortunately, by the time the patient notices his vision is not good, the optic nerve head has been damaged upwards of 50%. And for glaucoma care and sight preservation, I think that is the big challenge. How do we get these people in the early stages so that we can offer them interventions that will preserve vision?
Is there an age range where this is prevalent, or who's susceptible to it?
Yes, I think that's an excellent question. Anybody is susceptible, but from 35, 40 years upwards, the risk, the prevalence increases. And then the cause of glaucoma itself specifically is not really known. But along the years and studies, we've identified risk factors for people who tend to have glaucoma. And then the three biggest risk factors are raised eye pressure and a positive family history of somebody who has glaucoma, and unfortunately for us in this part of the world, people of African descent. So those three factors are the biggest factors, and unfortunately also it's only the first factor that we can manipulate, and so if that is appropriately done, we're able to preserve vision for a long time. That is the raised eye intraocular pressure. Yes.
You can preserve vision for a long time. That doesn't Sounds so encouraging,
Yeah.
because it presupposes that, well, you can just preserve for a long time. Eventually,
Something will happen.
something will happen.
Well, something may happen. You preserve vision for the productive years of a man's life. If you have a man going blind in 2016 and he goes blind in maybe 2027, you have achieved a lot.
The man is still human. The man is still alive. The loss of vision is a visual.
No, but most of the productive life, he is useful to himself and to his family and neighbors. Other risk factors for glaucoma is high myopia. Just being myopic can predispose you to having glaucoma. And like they all said, there is nothing you can do about this risk factor except it's detected early. But detecting of glaucoma, we've come to find out most people are detected when they're on a routine eye check. From the research, the last research statistics we have, that's 2012, it said over 80% of people who had glaucoma didn't know they had it. They were only detected when they went for an eye check, probably for something else, maybe for presbyopia or just to change their glasses, or because they've heard us talk like this and they want to go and check their eyes. So early detection can be done if regular eye check is made more, done more often by Nigerians. We all wait until there's a symptom. And now the primary open angle glaucoma, which blinds most people, doesn't have any symptoms. So unless something else takes you to the clinic, you may go blind from it.
Well, Dr. Kola Ogundimu, sight savers. You heard this.
Okay.
This is really scary, because I mean, if the condition deteriorates, then you expect that someone might just say, "Look, it's as if I'm not seeing clearly." But I mean, to think that one could have it and not really know until it gets to a stage where nothing can be done. How do you save the sight?
Well, thank you. Let me first say something that it is not all doom and gloom. Now, glaucoma, as you have said, is not a disease that we can usually say we have arrested and stopped completely. However, the fact is that we are born with over 1 million nerve cells that transmit signals from the eyes to the brain. And the destruction of these nerve cells, which is what leads to blindness, is not sudden, but occurs slowly over time. And even though it tends to be progressive, with good treatment, the majority of people will retain useful vision for their entire lifetime. I think we need to emphasize that. So we need to understand that the majority of people who are picked up early enough and treated properly, and when I say treated properly, it's not a one-off thing. Glaucoma is a lifelong treatment. It's a lifelong management by both patient and practitioner. It's not just the practitioner. But if they are treated properly and they maintain the proper kind of treatment over time, the majority of people will retain useful vision for their lifetime. Yes, there are some who, unfortunately, the disease is very aggressive and will progress no matter what one does. There are actually quite few. And there are actually some in which, over years, you keep on checking the visual fields. There are some tests in which we use to check the visual fields to know how much damage is being done over time. And you find that they are stable. Nothing is happening over time with proper treatment. So it's not all doom and gloom. The majority of people can be managed. And I need to also emphasize that, as my colleagues have said, is reliant on early diagnosis before they go blind, and then proper management and treatment. And I'm a public health ophthalmologist. And I want to pitch in a little bit regarding the public health aspect here.
All right.
Glaucoma is not a disease in which we can afford to wait for people to come to the clinic. Between close to 80% of people, as they have said, don't even know they have glaucoma and they're walking around the street. The only way to actually tackle this in the long term, and prevent our population from going blind from glaucoma is by having a systematic way of checking for who has glaucoma. It's not too tedious. Just an eye check every 2 years or so is fine with the appropriate persons.
You know, I'm looking at that. I'm looking at the kind of people we are really. If you set up today and say, let 100 people just go check their eyes.
You see over 1,000.
Right.
You see over 1,000. But the people here really is, for example, every day people go to get driver's license. It should be compulsory, actually. Anybody getting driver's license must have his eyes checked.
Yeah, that's part of the
Number two, any child going to school, particularly university students, on part of routine examination, they must have glaucoma test also. The regular checks, even within people working in offices, there should be regular checks at least once in 2 years. It is extremely important. People go for routine checks nowadays. Even in Nigeria, the awareness is increasing. People should also walk into the eye facilities and get their eyes tested. Incidentally, the test for glaucoma is simple and straightforward, and most of the time non-invasive. Simple visual acuity, checking the eye pressure. If need be, do the visual field assessment, which also the equipments are available in Nigeria. But to every citizen himself, what we always encourage people to do, because the fact that vision is lost gradually without you knowing, and usually starts with one eye before getting worse in another. You know, find that the vision in the two eyes are not exactly the same. We always encourage patients, even you at home, every citizen should actually, from the habit, when you're watching television, close one eye and look at the scroll, the lines of what is written in television. Then close the other eye and see. By the time you begin to see that, you see with one eye more than another eye, that's a red flag for you to actually look for us, so that we can look at the back of your eyes to tell whether you have glaucoma or not. So you see, even citizens also, as a habit, is a way of actually checking. Because for people who drive every day, when one eye is damaged, you never, as you're driving, you get to a junction, you think there's a car, there's no car coming. Meanwhile, this eye is actually gone. And that's a major cause of accident. And this is a call to the road safety and to the VIO. Everybody coming for either driver's license or renewal, or those people going for driving school, they must have glaucoma check. Extremely important.
Yes. Then, just additionally, just as part of systematic approach to early detection, the people we mentioned before who are at high risk, I think we should have a system to encourage these people by, if it's possible, to actually really force them. People with close family members who have glaucoma, people from, in this environment, from 50 above.
Right. Now, because I'm thinking, because you're talking about a family history, so now it would be that once you know in your family there's someone who's had glaucoma, you know, it would be advisable to just go check, and all the generations should begin to check for that regularly.
Regularly. Yeah.
In fact, the ones that have family history, really, from what Dr. Hassan said, what it means is that if, for example, I know either my father, my mother, my brother, my cousin, or my uncle, any one of them that I know has glaucoma, or there's a history because our grandparents, they never went to school, but we've had stories that, okay, my grandfather died as a blind man, or grandmother died as a blind woman, which means there's a possibility. You can ask question, when did she get blind? Did something hit her? You know, just gradual. Woman just became blind until she died. So you should not see yourself as a glaucoma suspect. You should present yourself to the facility for checking.
You know, the worry here is, it's said that as people grow older, chances are that their vision diminishes. So that might not immediately raise a flag that something is happening here. People might just say, well, after all, a person is over 60, 70, chances are that it's a normal thing to lose, to begin to, you won't have 20/20 vision at 70 or thereabout. So this begins to introduce a different dimension to it all.
Yeah, looking at it from my own perspective, I think glaucoma dictation should be looked at from the primary eye care point of view. If there's a facility that can dictate the glaucoma in every primary eye center, then people primary health center, then people can have their eyes checked and then referred to the secondary centers if they are suspects. If you are in the village, for instance, the rural dwellers are the worst hit in this issue. You can see a 70-year-old man who has never done an eye check. And then if he wants to do an eye check, he has to leave his community and maybe go 3 local governments away to have that check. And to the best of his knowledge, there is nothing wrong with his eye. So why should he do that journey? But if there is a facility near him where basic tests can be done, a simple ophthalmoscopy done, pressure done, the instruments are not too expensive, pressure done, and then the suspects are filtered and then sent to a secondary facility. If we look at it this way, we will achieve greater successes. That's the way I think is the way forward to achieve successes in glaucoma treatment.
So now that you bring up the subject of having, centers all over the country, the question most people would ask is that, is Nigeria well equipped to carry out these mass checks? Because you find out that, do you have the professionals who are qualified to do this?
Well, Nigeria is not well equipped for it right now, but Nigeria is perfectly capable of developing the capacity to do this. Why do I say it's capable of doing so? We have one of the largest health workforces in Africa. And even though persons have not been trained at the primary level at this point in time, there are people who have the potential to be trained to carry out the necessary, the needful. Secondly, Nigeria is not, we're going through some economic problems right now, but Nigeria is not a terribly poor country. We have enough resources in this country to develop a much better healthcare service and that can do the needful. And one of the things I look at, we work with states, we work with countries to develop healthcare services. And when I look at what we put in to make, as an NGO, to make services work, the reality is that we are more of facilitators and enablers rather than us doing everything. Much of the human resource, the base human resource, the know-how is already here. And what we come in to do is to facilitate and enable what should have been possible in the first place. To get to the next step is just a matter of having the focus, the planning, and putting the little that is necessary to take it to the next level. So it is entirely possible. And I also want to point out another thing. Glaucoma and loss of vision is not entirely in the 60s and 70s. Yes, it gets more as you grow older. And this is something we need to understand, and our population, our policymakers need to understand. Glaucoma can strike even in youth. And in particular in Africans, we see very young people with very aggressive glaucoma.
Young as in what kind of age bracket?
I'm talking about 20s, in the teens.
Congenital.
Some can be congenital. That's a very specific type, and also very treatable if picked up very, very early. Yeah. Again, it's about picking these things up early. For that, you need to have people to pick it up at the neonatology level.
Okay, let's even start from that point, the congenital glaucoma. Now, it is assumed that if you're dealing with an adult, you probably would go carry out a check once in a while. But if, it's congenital glaucoma, a child is born with this, at what stage do the parents begin to feel there's probably something not right with the sight of this child? Because ordinarily, no one just pays attention. You just say, baby is a baby, might not recognize things at this age, or it will take a while. So at what point do parents, or should parents begin to think that, look, I need to check if my child's eyes are, okay or are developing fine?
Well, for congenital, as the name implies, the child is already born with it. The child, from the moment the child is born, because of congenital anomaly in utero, the child comes with high pressure in the eye, with large corneas, therefore even coming with signs and symptoms of glaucoma, which is specific at the time of birth. Now, and that's why we say glaucoma management or treatment or diagnosis should be incorporated, or rather the eye care service itself should be incorporated into the primary healthcare system of Nigeria. And by implication, when we say introduce or included into primary healthcare, which means anybody, any healthcare worker involved in primary healthcare should be able to make diagnosis, at least diagnosis. Now, who are the primary healthcare workers? Even the people working at the PHC level, from the lowest, the community health extension workers, they are supposed to understand that if they deliver a baby, because now there's a policy of task shift, and therefore they also take deliveries. The nurses, the midwives, they take deliveries. That's their job. And they should know, as a baby is born, look at the eyes. Usually the eyes, the cornea is large, can be hazy, wateriness, and the child is always rubbing the eye. That is a sign of glaucoma. Once they see that, they should now refer straight to an ophthalmologist who will now do a thorough examination and make a diagnosis. There and then, surgical intervention can commence.
Before we get to this surgical intervention, I still want to start at that, continue at that level. Now, the basic birth attendant would need this kind of knowledge to know, because you have a baby, and mostly the babies their eyes are closed, and there are signs to look out for.
They're supposed to look at the eyes at birth. It's part of the training actually in the emergency obstetric care training. It is incorporated. All those eye care, healthcare workers. Now we're talking about healthcare workers.
Healthcare workers. How much of this training has gone to healthcare workers?
That's why it's a policy now as a government, incorporating eye care into primary health care.
What's the statistics like? We saw earlier on our report about the millions world over, and with such a high figure in developing countries. But you are the National Eye Hospital. What give us what we're looking at here? Because
in terms of congenital.
Yes, and then on a general outlook, because I'm assuming that.
Yes, thank you very much. It's not as the numbers is not as large as in adults, but you know the newborn has more longer years to live, so we take it very seriously. So we're talking of in thousands, not in millions. And as he said, we have eye health program within the training of all these other cadres of healthcare, and it's compulsory. So we expect that with the training, which also has practical component, we expect them to be able to pick up these children. And luckily, God is wonderful. For the children's glaucoma, there are symptoms. So unless a parent is just extremely unconcerned, the child will cry, will rub the eye will tear, will be red, and we expect, so the rate of blindness from congenital glaucoma is very, very minimal if the child is brought to us early, because we use drugs, we also do surgeries.
It's been said that many people don't pay a lot of attention to their health status. Now, here we are talking about a specialized part of it, that's eye care. From your experience, are Nigerians very good at minding their eyes?
I think it's a negative response, really, and health-seeking behavior is not
very poor.
It's extremely very poor, and for us in the tertiary centers, that is our biggest challenge. We receive people at the end of the story when the diseases are advanced, and like glaucoma, somebody comes, the nerve is totally damaged, and it's just accident just waiting to occur, because at that stage, the rate of damage is faster. So that is the challenge, and this week is aimed at engaging the public and talking to people and telling people, especially the people we have mentioned, who needs to really be more proactive and seek out experts to really identify whether they really have this disease or not early for appropriate intervention.
Well, what's the strategy for advocacy as this week has been observed?
The main attention is to create awareness that glaucoma could happen to anybody. It doesn't.
Rich, poor.
It doesn't choose any. It happen to anybody. Everybody has a chance, about 2% chance of developing glaucoma, apart from the risk factors. But looking at the primary eye care institutions we've talked about, it would be nice to train more primary eye care workers. But I think the optometrist is a primary eye care worker and is fully trained in the detection of glaucoma. Is fully trained in all the equipment used in early detection of glaucoma.
A lot of people will ask the same thing I'm asking. The optometrist, the ophthalmologist. So let's begin to put them in
Perspective.
Yes, perspective.
Yeah.
Well, I think as a government official, I'm in a good position to really to educate Nigerians really what category of eye care workers we have.
Right.
That is recognized by the government of Nigeria.
Right.
Of course, at the highest level is the ophthalmologist.
All right.
The ophthalmologist is a medical doctor, trained from the university, practiced as a physician before going to specialize another 6 years plus to become an ophthalmologist. And thereafter, he can even go for further specialization into subspecialties, either anterior segment, oculoplastic, glaucoma itself. So even the glaucoma itself, there are subspecialists amongst us who actually specialize only in glaucoma.
Just specialize in glaucoma.
Only in glaucoma. Now, these are the pinnacle of eye care workers, and these are the ones that train all the other eye care workers. Of course, we have other ones that are at lower down the level. Like she mentioned, that's one of which she is an optometrist. Optometrists are also eye care workers. Largely, their training is to take care of one segment of the diseases of the eye or the problems of the eye, which is optics and refraction. Of course, the greatest problem of low vision in Nigeria and worldwide is visual impairment is from refractive errors. And that's why optometrists actually have an important role. In fact, they are key in the management of refractive errors. Besides, myopia, hypermetropia, astigmatism, and the rest of them, and of course, and other ones, low vision, provision, low vision devices. We also have other eye care workers, the ophthalmic nurses. These are veritable and important players, in fact, if not the pillars of our practice as ophthalmologists. Now, which government also recognizes. Those are nurses that haven't finished their RN. They now go for additional training, 1 year plus, in fact, 2 years, to become ophthalmic nurses in the institution. We also have the optical technicians. Those are the ones that are responsible. They work directly with the optometrists because in the process of producing glasses.
Right.
Now, these are the categories. However, in terms of primary eye care, anybody below the ophthalmologist is a primary eye care worker. And when we say primary eye care, meaning you are able to detect the basic diseases. Once you detect, you refer him to the ophthalmologist.
Now, who are the group of professionals, if you mind, that generally are referred to as opticians?
Okay, opticians, yes. Now, these terminologies actually varies from country to country. Of course, the first, like I mentioned, are the ophthalmologists. In some parts of the world, of course, like I said, ophthalmologists are medical doctors, are physicians. Therefore, they know the human body as well as the eye. In some countries, ophthalmologists actually recruit workers who are interested in what they call hospital assistants or doctor's assistants, or those that are interested in eye care. They sit with us, or they sit with the ophthalmologists in their clinics and train them. In some places, they are called opticians.
All right.
However, the world is evolving. The world is advancing. Therefore, in the process, particularly in America, they now decided there should be an extra training, an additional training, beyond that of just optician, who perhaps just gives glasses, who cuts glasses. No, let it be a special field on its own. Optometry now was given birth to. Therefore, optometry goes beyond an optician or an optical technician. And optometrist, like she is a specialist in her own area, below the ophthalmologist, but largely responsible for diseases as a result of refractive errors. And they are the ones that are mainly the ones that give glasses. So in some places they are called opticians, but actually now worldwide, the acceptable name is optometrist.
All right, the phone lines are open, and we'll have a first caller from Abuja here. Daniel calling in. Hello, Daniel.
Hello. Hello, good evening.
Yes, good evening. Go ahead.
Hello, good evening.
Good evening.
All right. I actually want to contribute in this way that what federal government is doing, I think they are not really doing very much. But going to these private practitioners, you know, the cost of running us tests and whatever is very alarming, very high, and average Nigerian cannot afford it. So what is the federal government doing to bring this in, maybe in a kind of subsidizing the rate or the amount, and bringing it very, you know, very, we have all these facilities in general hospitals. Are they affordable? And I think that's the area I'm really very much concerned about. Thank you so
All right.
much.
Thank you. That's straightforward. It's talking about the cost of eye care.
Yes, okay. I think that's a very nice question. Worldwide, I think that the challenge is we call it out-of-pocket expenditure. You know, you have to pay for service from your pocket, and that has limited how much people can access. And I think the government is going towards health insurance, which is supposed to deal with this at various levels, both community, primary, secondary, and tertiary levels. Health insurance. I know the government is working hard to build on that, social insurance at the local government, and then the national health insurance, to expand it, to make people to have access to really deal with this out of pocket. You really need to be very rich to really exactly, because eye care is expensive. It's technology based. I don't know whether you want to.
By the way, just before you comment, is treatment or is glaucoma covered under the NHI scheme?
It is covered. It is covered. The basic drugs and even the surgery, but we want to. We're increasing advocacy for total coverage, including these new high-end drugs, the prostaglandin analogs, PGAs, and I'm sure we will win advocacy.
Actually, I think insurance cover is the best. But right now, as it is, the drugs are limited. But as the NHIS is reviewing its laws, and NHIS every day reviews her drug that is covered within the insurance cover. You know, therefore, the newer drugs, like Dr. Hassan mentioned, are going to be introduced. But for now, it's just the basic drugs, which is really, in all fairness, not enough.
We'll come to the issue of the drugs. Yes, you are going to come in here at this point.
Yes, I think, you see, the more you go into the management of glaucoma, the more expensive things get.
And if we're looking at a lifetime here.
Yeah,
yes.
exactly.
And the diagnostic equipment, too, can be quite expensive when it comes to early detection. I mean, the basic ones we already said are not inexpensive, but the more you get into tertiary level care, the more expensive it gets. And the person who needs tertiary care is not necessarily the person in the federal system, or any person would need tertiary level care. And therefore, the issue of getting a system of cost sharing in some way, health insurance or whatever, is absolutely critical. There is no way we can cover our people and get enough management without that. And I think both the population as well as the government needs to come into this, because in some cases it's also the population that is a little resistant to buying into health insurance and so on. But that is what insurance is about. We know we cannot all afford the heavy cost, therefore it's about cost sharing. Okay. And we need to learn to do that.
All right, we have another caller on the line who's calling in from Delta. Hello, just introduce yourself quickly and go ahead. Caller from Delta.
Hello, good evening. Can you hear me?
Yes,
Hello, good evening. Can you hear me?
we can. Go ahead.
Hello?
We can hear you. Go ahead.
Hello, can you hear me?
Yes, we can. Go ahead.
Go ahead. Okay. I'm a judge from Delta State. I've been researching on this for the past 11 years.
Ooh.
Yeah, I've been researching on this for the past 11 years. And fortunately, it's very painful that the Nigerian doctors are distorting information. Yes, there is a reason for that. Actually, optometry started from optical physics. And because of that, most ophthalmologists have refused to acknowledge the fact that optometrists are primary eye care providers and they are medics. The reason they say they are not medics is because they have not done the MBBS in school. Having done a lot of research on this for the past 11 years, optometrists has evolved from just optical physics to the level they are today. Before now, you had optometrists who just did a 4-year program and they were just merely refractive specialties. But today, they handle pathological cases and refractive cases, which I'm happy Dr. Khan has talked about. Right now in overseas, optometrists are known as medics who are specialized in primary eye care. Now, the question you asked, Stoba, is the different strata. Now, the first strata in eye care is the ophthalmologist. The ophthalmologists had their first 6 years training as physicians, and then they go into another 6 years for their residency program and specialize in ophthalmology. And of course, he said there are various other sub-specialties in that field, which I agree with him as a researcher. Now, the next on board is the optometrist. And the optometrists, currently, they have a 6-year training program in the university. And that 6-year training program qualifies them with their OD, which is Doctor of Optometry, which makes them to handle both refractive and pathological cases. When it comes to surgery, they refer. When you have cases that is above, because every strata has its limit. But unfortunately in Nigeria, the opticians pride themselves as optometrists, which is wrong. They don't even see that. They have trained these persons. From my research, the opticians are the technicians in the field. They cut the glasses into the frame. The ophthalmic nurses in fact, this is a recent development in the nursing profession. Before now, we had midwifery. But right now, what we have is different specialties. We now have pediatric nurses, we have ophthalmic nurses. Now, the ophthalmic nurses are now specializing in assisting, like Dr. Khan said, which I agree with him very well, assist in the primary health care, like when you have the ophthalmologist in the theater working, the ophthalmic nurses, they assist in one area or the other. Why the opticians? I repeat, the opticians, they don't have any responsibility in diagnosing refractive or pathological cases. But most times you go to some optical clinics, they pride themselves as doctors, they crest the DRO, which they did not get at all by any virtue of training. Right now, in Nigerian institutions of health technology, they train opticians in that area for them to have a better specialty, not just having it by the wayside or by the roadside. And so Nigerians, we need to evolve and we don't need to distort information. Right now, all over the world, in eye care providing, the ophthalmologist is number one, the optometrist is number two, the opticians, they're just there to assist. And I want to advise that the world is listening and is hearing. Opticians, stop priding yourself as medical doctors. I really want to congratulate you for the wonderful contributions on glaucoma. It's been a very good topic. To let you know that I just ministered this, I had to go into, in fact, I wanted to go into the study of optometry. But somewhere along the line, of course, because of my research, you know, I got all the information that I needed.
Thank you very much.
We should not distort information. Nigerian ophthalmologists have refused
All right, you made that point already.
But
Yes.
when he thinks of the
Yeah.
technicians,
Yeah.
not see their doctors, their medical, their medics.
Yeah.
It is also the problem in Nigeria.
Okay.
The medic is a medical doctor who
All right.
trained and became an ophthalmologist. So he should also extend the caution to everybody.
Okay,
who the
fine.
ophthalmologist.
Okay, yeah, we brought it up, but while the major aim here is not to, to bring about the
No, but it's important. What
the discussion here.
What he's saying is actually very, very important.
Yes.
Now, because of the fact that, because of impunity in Nigeria,
Right.
which also pervades also in the healthcare system, everybody calls himself a doctor.
All right.
And the ignorant patient, once he has any eye problem, if he sees eye clinic, as far as he's concerned, the person is a doctor. And that is the point he's making. If you are not a doctor, a medical doctor, becoming an ophthalmologist, you have no business going beyond primary eye care.
Okay.
You have no business going beyond primary eye care. That is the point he's making.
Okay.
Even though he's talking more about ophthalmologists, but anybody below ophthalmologist is a primary eye care worker. No, they should restrict their activities at primary health care level. That's what he is saying. We should not deceive
Well,
Nigerians.
the important thing for us here is to look at how the various professionals who are into eye care can provide this much needed service that we do not have here. So that, like you said, people who need to take care of their eyes know exactly where to go and know at what level they have to start doing that. And of course, like was raised earlier on, the cost of eye care, which most probably is why many people would not pay that much attention, because you're grappling with so many other things, and then it comes to eye care, and that is so expensive. So chances are people will just say, okay, probably it's just a small eye infection, and one or two eye drops, that would be it. Yeah. So let us talk about the cost of treatment now for glaucoma.
Okay. First of all, you look at the medical treatment. There are three prone approach to the management of glaucoma. From medical treatment using drugs to surgical, which either use surgical intervention or laser. Now, for medical treatment, like Dr. Ogundimu mentioned, drugs are expensive, really. That's the truth of the matter. Even the cheapest beta blockers, anti-glaucoma agents is between 1,000 and above. Now, by the time you are going to prostaglandin analogs, you are not talking about 4,000 or 5,000 per bottle. Now, if a patient is going to be using those medications, for an average Nigerian, with an 18,000 naira minimum wage, what it means is that half of his salary actually will be going on the treatment of glaucoma. That's medical treatment. If you get to surgical, fair enough, you have surgery. If you are lucky, the pressure goes down, you have to maintain pressure for a very long time. You may not be on medication. If you're not lucky, you have to come back and go back to medications again. Ditto for laser surgery. So now, if one looks at it, the surgery, the management, both whether medical, surgical, or even the laser, is expensive. Okay. Quite frankly.
We'll return to that, but let's try and get this call through. This is from Benin. Amos calling in from Benin. Hello.
Hello, sir.
Yes.
It's not optometry, ophthalmologist matter.
Yeah, I want to especially appreciate all of you in the studio talking about this subject matter. What I really want to contribute or cite here is that I want to know exactly what the federal government is doing concerning our elderly that are going blind on a daily basis. Because a lot of them, when you go to all these private clinics that offer eye treatment, you discover that the treatment tends to be very high. And some of these our old men that are going blind every day, they don't have enough resource, to do this. I went to the, I was having eye issue the other day. I went to the clinic to do a check. And I was told that I was going to buy a glass worth 16,000. You get it? So for me, I think the federal government needs to do it. There was a time when the former governor of the state, Comrade Adams Oshomole, started, age group that could benefit from this eye problem. But at a point, we never saw anything coming to bear. So I think the federal government needs to really come out, do a lot of sensitization, because sometimes what really gets people blind is just common. Sometimes, They just wake up and they have something on their eyes. They don't even know what it is. There's no orientation, no place to go. If you even go to a hospital, they'll tell you to take cartridge. And these men, they don't even know what it is. So we really want the federal government to come out and put an agency or a machinery in place that will educate these people and then subsidize, the eye treatment for them so that on daily basis they cannot go blind. In my community where I came from, in the Eastern Central, for example, I saw a man who could not, afford it. He went to the hospital. He knew he was having a problem. But the cost, at an Irwa Specialist Youth Hospital was too much for him. So he has to go home before the 2 eyes, that was it. So please, we want the federal government to really, if they can do it for age 60 and above, we'll be very happy, sir, because a lot of them are going blind every day on, issues that can be treated.
Okay.
Thank you very much, sir.
Thank you very much. Okay. Well, that's still staying with the cost of treatment and the cost of eye care generally. Because when you even zero in onto glaucoma, it becomes worse.
And the cost of treating glaucoma can be enormous when you calculate how long you've done it. But if you calculate what would have been lost if this wasn't done, if you spread it out, it's not as bad as it sounds. I think it's how important we take these ailments to be, or if we understand it. What makes glaucoma patients not adhere to their treatment is more or less the lack of symptoms. A man is using medication and he is not getting improvement in vision and he has no pains. Sometimes he feels that is an expense that can be overlooked.
Right.
But like I was talking to Dr. Sena when we're out, I think the tertiary institutions could go a step further to help these patients, because we have a lot of patients dropping out of medication, not completely because of cost. Time should be taken to explain to a patient exactly what he is in for. You have a patient who has gone to a clinic and has been diagnosed of glaucoma, referred to appropriate quarters. He goes to the clinic, sees the specialist, and then takes one treatment, two, and you don't see him again. And then you see him 5 years later, he's blind. Yes, it's the patient's fault, but I think in the healthcare system, we could do better. We could have counselors who take time to explain to this patient that once you start glaucoma treatment, it is a lifelong treatment. Even when you do surgery, once you have been diagnosed as a glaucoma patient, you are an eye patient for the rest of your life. Even if you have done surgery, you still have to see your doctor from time to time, depending on the arrangements you have with your doctor. Like we're talking about glaucoma, if the doctor is in the tertiary institution and is not available to follow up every patient, there could be a delegation of duties. You could go here for so months and then back to your tertiary provider. As long as glaucoma is looked at from tertiary to primary, we will have these issues. And whether we like it or not, in the eye care industry, until we begin to work as a team with synergy, we will lose vision. It's about the patient, not about the practitioner.
Yeah, I like that, the alliteration there, you're all in the business of taking care of the eyes, vision, and if there's no synergy, we'll lose vision. That's even for the healthcare professionals. But let's go over to Jos and then hear from Abdullahi, who's calling in. Hello, Abdullahi.
Yeah, Mr. Firon, good evening.
Good evening.
Hello, Mr. Firon.
Yes,
good
go
evening.
ahead. Go ahead.
Right. I'm a glaucoma patient, so I'm
Turn down the volume a bit. Right. Good.
That is really bothering me. Now, in taking I'm a patient and I'm using Xylitol. That is a prescribed drug. Right. Now, my question is this. Now, the Xylitol reduces the pressure, right? It reduces the pressure of the eye.
Yes.
And of course, my sight is declining. My sight is declining. I hope you're getting me.
Yeah.
Now, the question is, where does surgical operation in here, does it really help perhaps in checking the damage to the nerve? If it doesn't check, then what is the difference between the drug and surgery? Thank you very much.
All right. So are you still there, Abdullahi? Are you still with us?
Yes, gone.
Oh, no.
Okay, because we would like to know, initially you said you are on a particular drug. We didn't quite catch the name of that drug. Could you repeat?
Yeah, I'm still with you. I'm still with you.
Yes, can you repeat the name of the drug you're on?
I've reduced the volume, so I'm not getting you. Now my question is this. Are you getting me? Hello?
Yes.
Yeah?
Hello?
Yes, go on.
Hello, Mr. Cyril?
Yes, go on.
Hello?
Yeah.
Yeah? Okay. Good. Now my question is this. Fine. My question is this. Now, when the surgery comes in as a glaucoma patient to check the damage in the nerve and perhaps improve the sight, that is the vision of the patient. And if surgery doesn't help, what about the medication that is Xelatan or whatever that is prescribed?
I think that's
Or Timolol?
Timolol. Okay, Timolol.
Which one comes in first and which one really increases the vision of the patient? Thank you.
All right, thank you very much. Well, the professionals are here and they got that.
I think that's a very good one too. The treatment of glaucoma is a dialogue between you and your doctor, and at some level, we presume that your doctor is well trained in glaucoma management. Drug, surgery, or laser, both of them are initial options. For us in Africa, for the factors we have discussed about cost, access, and complications, quality, and availability, the primary surgery is advisable. So in very good hands, and we're working on that, training our glaucoma specialists to actually really offer surgery as primary intervention. And if we're successful, you're done for life. But you are still our patient, we still need you. If surgery is not readily available or the patient is not willing to have surgery, drugs, topical eye medications are options. When the topical eye drops fail to reduce the pressure to the level we want, we also bring in surgery stroke laser. So it is depending on the dialogue between you and your patient and your doctor. That's very important. Then most importantly, if you are on treatment and your sight is going down, you need to have a thorough assessment by your glaucoma specialist to really determine whether the cause of your visual deterioration is still glaucoma or other things that can happen to you in the eye. And if it's glaucoma, then we'll change strategy. Either increasing the frequency or the number of drugs or moving you to surgery or laser. I think that is what we do.
So the thing is, it's quite possible that even as a glaucoma patient, you're receiving treatment or haven't had, it's quite possible that the other factors might also come in and be responsible for the eyesight, the dwindling eyesight.
Most prominently cataract. So it can come in.
Which is also a complication of some of the drugs and surgery. And we also need to let people know that surgery is, what is done in surgery is to try and create a new drainage pathway to reduce pressure.
Okay, so like he asked, would it make a difference?
Over time. Honestly, I cannot say on his particular case.
Okay.
Because there are so many factors that could be involved. That's why Mahmoud was trying to explain the various things.
Okay.
So he needs to see a glaucoma specialist. By the time he gets to this level, he's not a general practitioner he needs.
Yes.
He needs to see a glaucoma specialist to actually get a clear view of where the glaucoma is and what progression is likely to continue. And then surgery doesn't mean once you do surgery once, that's it.
Yeah.
Repeat surgery is possible. There are different techniques, some more advanced than the others to further reduce the pressure. So there are more treatment options, I'm sure, that are available to him. And that is why we mentioned this thing that a glaucoma patient, once a glaucoma patient, you're always a glaucoma patient. It's not one like cataract you can say you are treated and you are gone. No.
And for the sake of the caller, I think
All right.
we should probably go a step further.
Yes.
He called from Jos.
Yes.
That's fortunate for him because incidentally we have excellent eye care practitioners in Jos and its environs. One will advise him to quickly get in touch with our colleagues at the Jos University Teaching Hospital, or he could go to Evangel Hospital in Jos. Incidentally, they are very advanced. They have very advanced tertiary eye care.
Just University Teaching Hospital or
Evangel Hospital, which is a teaching hospital itself.
Okay, it's
all in Jos. So we advise him to immediately go and get his eyes checked. Then the ophthalmologist there will actually assess him and tell him what is the way forward.
Okay.
I want to add something, not particularly for the caller,
Okay.
but when to do surgery for a glaucoma patient.
All right.
There are so many things to consider before you decide to do surgery. There are patients who, from what you've done with them, you know they're not going to continue these medications you have given them.
So
You will have to think of surgery. And then you see a 15-year-old with glaucoma and you think you want to place him on medication for the rest of his life. He must be an angel to do that for you.
Okay.
So you will consider it. Then an infant, you will have to do surgery.
No,
so
no,
there's-
infant, those ones is
there-
outright
there-
surgery
There are
actually.
some situations where
Congenital
you
glaucoma is surgery,
consider,
outright.
there are so many other things you consider before you say, let's do medication
Okay.
or let's do surgery.
And that's where we'll go next when we return from this short break. Stay with us on NTA Tuesday Live. We'll be back shortly.
Nigerians, our fearless officers and men of the Nigerian military are winning the war against Boko Haram. Today, all occupied territories have been recovered and Boko Haram has been degraded. Our affected brothers and sisters are getting their lives back. However, they are now after you and me. In our mosques, churches, schools, motor parks, markets, entertainment centers, and public gatherings. Be vigilant. Be security conscious. Report suspicious persons, objects, and movements to the police and other security agencies. The security of our nation is a duty for you and me. Nigeria unite against terrorism.
This message is brought to you by the Federal Ministry of Information and Culture.
The struggle for independence had been a long and tough one. Our founding fathers and compatriots sacrificed their comfort and even shed their blood. We cannot at this point in history afford to spirit away their sacrifices for immediate but temporary gains of today. Let us emphasize what unites and not what divides us. Working for the unity of purpose with a stronger vision for a better tomorrow. NTA, growing with the nation.
Nigeria, the only country we can train with remarkable potentials to excel. Let us believe in ourselves and change our attitude for the sake of our country and generations unborn. Let us revive our cultural values, which are our essence as a nation. Let us renew the spirit of patriotism and hope in our dear country. Do not take or give bribe. Be punctual always. No more African time. We can't expect to be global citizens and operate on African time. Join the queue. Insist that people are attended to on a first-come basis no matter who they are or where they come from.
Nigeria, good people, great nation.
Make you report any crooked person, object or wakajube movement to police and security agent demo.
The security of our nation now work for all of us, plus including me and you.
Nigeria, make we unite against terrorism. Now, Federal Minister of Information and Culture bring on this message.
NTA Tuesday Live, a network issue-oriented innovation talk show.
Thanks for staying with us. It's Glaucoma Week, and we're here talking about how to manage this disease, the incidence in Nigeria. Just before the break, we were looking at the cost of treatment, the cost of eye care, and taking off from the point of the last caller, we're now talking about treatment, what side effects, if any. Would surgery make a difference, or would it just be drugs? And as been said by the professionals here in the studio, once a glaucoma patient, it's a lifetime thing. So let's look at this treatment.
Well, let's start with the medical treatment. The fact that one is applying medications to his eye, drugs is a double sword thing. Drugs have positive effect, and we say they have negative effect, which we call side effects.
Right.
And therefore, the fact that one is going to be on those drugs for life have their own effects, not just on the eye, but even on the body. And that's the reason why we have different combinations of drugs. Sometimes by the time patients applying medication, he may come back to you even the next day, actually, with pain in the eye because of application of the drug. That's an immediate side effect of the drug, as you are referring to. And before that, there's even the burden of constant application of drugs, and that's the stress, the economic burden, then the burden on the patient himself. There are specific side effects to the eye. Some medications on their own can even create more problems to the eye. The surgery on its own can result to additional complications, which the commonest really is cataract.
Okay. But that also can be taken care of.
Oh, absolutely. If cataract occurs, but of course we are not always happy really going into the eye twice. Most of ophthalmologists doing glaucoma surgery will always prefer to go into the eye once, because you look at the fact that if a complication should arise, i.e. cataract, you may have to open the eye again. Nobody wants to open the eye twice, in all fairness, but complications are normal in any surgical operation, but as much as possible to avoid that. So those are the complications. And of course the laser itself. The first complication of laser is failure. You can apply the laser. Basically, like Dr. Gundi mentioned earlier on, the whole essence about the surgery is creating an extra passage for the fluid to exit the anterior chamber of the globe. So sometimes even after creating the chamber itself, it can close back again, which may necessitate another surgery. But the beautiful thing about laser is that even after application of the laser and the tunnel closes, you can apply another laser again. Of course, lasers have their own side effects in the eye, damaging the lens, damaging the optic nerve, damaging the retina, and other parts of the eye. But as the technology is advancing, lasers are becoming safer and safer and safer.
And more expensive too.
No, incidentally less expensive actually. In the past in Nigeria, we had very few centers that offered laser surgery, laser procedures. But now, virtually everywhere, there are a lot of centers now.
Even private.
Yes, a lot of private facilities offer laser. So therefore, the more the facilities are available, the cheaper it becomes. So laser are becoming more affordable, more accessible, and therefore cheaper. To the patients.
Now, it's a little bit complicated when we're talking about glaucoma, because everyone would tell you basically that, as they say, prevention is better than cure. But in the case of this disease, what do you really do to prevent it? Because you talk about tension, and all right. So, how do you do that?
Yeah, I think that is the challenge, and. You can only prevent something you understand the primary cause. We don't understand the primary cause of glaucoma. There are a lot of researches dealing on genetics and very extensive, complex researches trying to identify the genes that are associated with glaucoma. But so that is research. And has this been brought into public health for application? No. So what is available to us now is early detection in this context, and we have talked around early detection. Yeah.
So you can't say to anyone, look, don't do this so that you don't increase the tension in your eyes. I mean, it's just that, well, it could be a chance in 10, a chance in a million,
Well, we can look at other causes of glaucoma, like trauma.
All right.
trauma is a cause of glaucoma on its own. A child, which is a cause of secondary glaucoma. Let me give you a simple example. Grandparents carrying their grandchildren. The grandchild can hit the parent in the eye, or rather on the eye. That can actually develop a secondary glaucoma. So more or less, you must try to avoid anything that will hit your eye.
Okay. Well.
What you said, we all agree that early detection is the key. And early detection, if you do an eye test once every 2 years, you're most likely to be caught early enough. Okay. And if you're caught early enough, then we can preserve vision when nothing is lost or little is lost.
Okay.
So early detection.
I'd like to come to you, but just a moment after this call from Maiduguri. Abba calling in from Maiduguri, I believe. Hello?
Yes, Abba calling from Maiduguri.
Yes, go ahead.
My question is just very simple. I just want to ask about what kind of natural fruit would one have to be taken to make the eyes very strong? Then my second question is, most youth nowadays used to these eyeglasses, black eyeglasses. Is it going to affect the eye as a young person keep on using eyeglasses all the time? By the time he's older, would that have a side effect? I just want to know about that.
All right. Okay, so
let me take the second one first. That is an old wives' tale that keeps on going around. That the wearing of spectacles does not cause any long-term problems to the eye at all.
Okay. The dark glasses.
Glasses.
Those dark shades or the sun shades, as they call them.
Sunshades are actually quite good if they have the correct type and used appropriately.
Yeah,
in the sense
that sometimes
they prevent,
it's used to mask certain things.
Yes, right. But when used appropriately, they reduce the amount of ultraviolet light that gets into the eye, which can slow down some of the aging processes. I'll put it as aging processes that leads to some conditions in the eye, including cataract.
Okay.
So, but let's probably be very clear about this. Use of spectacles for visual acuity correction is perfectly safe as long as they are modern plastic glasses that are not going to break on the other person's face. So there should be no fear of whether it is a child of 6 months or 1 year. They can use it. It's not going to affect in the long term.
After proper refraction.
And they will have a good proper refraction by a qualified professional.
Okay.
Now, in terms of what people need to
diet to make the eyes.
The important thing is having a good balanced diet with the necessary micronutrients, particularly vitamin A, the B
what's
complexes.
Good for the eyes.
All those things are good for the eye. So a good balanced diet is key and very important. Now, we just going back slightly before then about the issue of prevention. Let's not forget that there are two kinds of prevention. We call primary prevention is what people usually think about, preventing the disease. But as my colleague here pointed out, sometimes prevention is preventing the complications from the disease, the progression of the disease. It's called secondary prevention, but that is also accepted as a form of prevention. And because that is what we know how to do right now, and even for the near to medium term, that is what we are going to be able to ameliorate. That should be our area of focus. There's no point. Let's leave the area of primary prevention to the research at this point in time.
Secondary prevention.
Let's focus on early detection so that we prevent people from going blind.
But I'd like to take this matter of trauma that might cause it to a little further. When you talk about trauma, what about athletes, for instance? You say, you give an example. You say a child might be carried by the grandparents and they just hit them on there. What about those whose work, whose way of life, whose living is to punch people in the eyes like boxers? The sport of boxing, for instance.
That's what you call occupational hazard.
Yeah, it's the occupation.
Occupational hazard is part of life. And that's why those boxers are highly insured. Because they know that the possibility of damaging their eyes through their own jobs is very high. Therefore, the premium on them is equally very, very high. Because there is no doubt about that they are highly, highly, highly prone. But interestingly, as God has made human beings. God constructed the orbit to protect the globe itself. The eye, as we are seeing it from outside, has a lot of protective mechanisms ab initio. So while boxers are highly prone to blunt injuries to the eye, God has also provided some level of protection for them. Tennis players also, theirs is even higher. Footballers less. Tennis, because the ball is small and it's likely to hit the globe directly, avoiding or rather evading all the protective mechanisms of the eye.
You didn't play football in school, did
Oh,
you?
we all did play football.
Yeah. Yes, but having said that, let's not forget that any kind of contact sport or high velocity ball sport does have the potential of causing eye injury.
Okay.
And glaucoma, though a long-term complication of even what can be relatively minor trauma, we shouldn't forget that there are other kinds of things that can happen. You can bleed in the eye, which we call hyphema, which can actually lead to the loss of the eye if not properly managed. And the eye can even be torn, leading to lacerations and loss of the eye. So all persons who are using some kind of contact watch should take necessary prevention. Protective eye wear.
Right.
Very important.
Okay, back to the phones from Akwa Ibom. We have Udo who's calling in. Hello.
Oh, go on.
Oh, we lost that call, right? Well, just try to keep the calls coming. Well, moving on. The World Health Organization, the World Health Organization has proposed a reduction in blindness by the year 2020. And of course, that has been brought down to the community level. What are we doing as a country, Nigeria, to achieve that target?
Well, first of all, I'll start by saying that as a government, the Federal Ministry of Health, working with various partners, and of course largely supported by Site Savers, Dr. Kola Ogundimu, in 2007, 2008, right? Yes, conducted a national blindness and low vision survey. The whole essence of that survey by the government of Nigeria is to see really what is the status of blindness in Nigeria, what are the causes of blindness, so that plans can be put in place to actually address those causes, so that one, to mitigate against the progression of those conditions. Secondly, those that have the conditions, what can government do about that? And after the survey, of course, through the National Eye Care Program in the Federal Ministry of Health, working with various partners, and specifically National Eye Center and other eye care workers, have continued to address those conditions. One, looking at the number one cause of blindness at that time, cataract. Secondly, glaucoma. For cataract, government has done a lot. At the moment as I'm talking to you now, the Federal Ministry of Health initiated what they call the Rapid Results Initiative, providing funds to hospitals, even National Eye Center, so that they can actually treat indigent patients free of charge. That is the direct address to that. Secondly is the issue of awareness creation. Government of Nigeria, not only Federal Ministry of Health, Ministry of Information, like what Cyril Stoba is doing today, is also what government is doing to create awareness. And for glaucoma, really, like what I agreed here, it's all about awareness creation. So government is also looking at the areas of awareness creation, which is actually very, very important. And beyond that is the issue of insurance cover for everybody.
Okay. Right, let's go back to the phones. Hopefully, Lagos, Bankole calling in from Lagos. Hello.
Good evening, sir.
Good evening.
Yes, sir. This is Mr. Bankole from Lagos, sir. I've been watching that program before the NEPA took light.
Oh,
when the doctors, when they are saying that someone should use the hand to cover one eye, then I did it. Then I covered the left side and use the right side to look at the side. That one is so dull. That is my eye. Then when I covered the right side, that one was too sharp. Please, I want to know what can I do, because this the health care that federal government is giving us, when we get to the choosing hospital that we choose, because I'm using a hospital at Ikeja, then After treating us, they treat us fine, whatever. When we get into the drugs, they will not be telling us that the amount and the government is not paying for that one, that we should go out and do it by ourselves outside. This bank calling for Victoria Island.
All right.
First of all, your fishes are marine.
Okay, fine. Okay, Bankole, that's the same question. Now you heard him clearly. First, he carried out that.
What I just mentioned.
Yeah, what you just mentioned, and he noticed that one eye is sharper than the other. What does he do? And then two, we're back to the issue of the cost and coverage on the NHIs. So they go into a hospital and they just give them the basic attention and say, look, you have to go and buy the rest.
Well, first of all, now you see, we have achieved an immediate gain from this program. The fact that we're creating awareness, if we just simply close one eye and at the same time close the other one, and you actually assess yourself to see the difference in the vision. You know, we're happy that he has learned from that, and what one can say to him is that all is not well. It is two eyes, you know, so he needs to see an ophthalmologist as soon as possible. He is talking about somewhere in Ikeja. Of course, we have the Lagos University Teaching Hospital in Ikeja, and he has to visit the ophthalmologist there. But he also went further to say that he went and insurance cover isn't that much. And that's what we mentioned earlier on in the program, that of course the National Health Insurance Scheme is a program that is constantly evolving. Therefore, they constantly review the drugs on their list. Right now, I am aware the Ophthalmological Society of Nigeria is advocating for the review of those drugs. So that the drugs that he mentioned, he's very correct in all fairness. The basic drugs, which were thought to be the first-line treatment for glaucoma, are no longer first-line treatment for glaucoma. The first-line treatment have now stepped up, which are actually beyond the list of the health insurance. So really, and I'm sure the health insurance also is watching, you know, to ensure that quickly the review of the drugs have to really take place, because glaucoma awareness is increasing. Therefore, people go to hospitals to check themselves. More diagnoses are made, and we have to really provide treatment for these patients.
All right. From Kaduna, we have Ibrahim calling in. Hello, Ibrahim. Ibrahim from Kaduna.
Hello.
Yes, hello, go ahead.
Hello.
Yep.
Hello.
Ibrahim, go on.
Hello. Hello.
Your name is on screen, Ibrahim. Go ahead with your question or comment.
Hello.
All right. Obviously, Ibrahim hasn't been listening to all the things we've said about going straight ahead once your name appears on screen. All the other callers have been doing just that. This is a question that I really would want to find an answer to. Is there any form of stigmatization of glaucoma patients? Have you come across a reason why some people would not want to open up about having glaucoma and say, you know, people look at them and see them as a potential blind people? Or those who have undergone surgery, do they face any social challenges? For instance, we were expecting that we would have someone who, a glaucoma patient on this program tonight. That hasn't happened.
Well, coming on national television to say you have glaucoma is different from walking on the streets and expecting people to stigmatize you. With proper sensitization, people will come out and say they have glaucoma. But what we have more is denial syndrome amongst the patients. You see a patient, you diagnose of glaucoma, and he says, it's not my portion. And he won't do anything about it. It takes a long time before they come to terms with what you have said and then agree to take treatment. So the denial syndrome is higher than stigmatization. So maybe he is the one stigmatizing himself.
Okay. But Stuart, I think what you said is very correct. Really, the few patients that we actually encouraged to feature on network television today really declined, because the truth of the matter is that we are living in a strange society. Strange in the sense that most of our patients, especially patients who are high-class patients, actually don't want people to know they have glaucoma. I tell you, give one simple example. Somebody who is a politician, by the time his community or his adversaries get to know that he has glaucoma, probably they even lay their hands on his medical records, sees that he has an atheist glaucoma, they could actually give a negative campaign against him. They say you are going to vote a blind man.
Okay.
And that's the reason why people actually run away. But there's simply no reason on the fairness.
Okay.
There's simply no reason.
I would actually suggest that is a general problem with maladies in Nigeria. That we do not like to. We have a sense of confessing that it is not true, rather than accepting and trying to work out a problem. A medical problem.
Okay, there's the next question I'll ask, but I'll hold on until we get in this call from Kaduna. Tonia calling in from Kaduna. Hello, Tonia.
Good evening.
Yes, good evening.
Hello, good evening.
Yes, good evening.
Out of
She's actually talking. She's talking.
Hello, the line isn't clear. Hello, Tonia. You want to repeat your question or comment?
Now with patient taking antiretroviral drug.
Okay. All right. Yes, what about that? Oh, there.
You find out that something like that. How can you help?
Okay. Okay, patient who's on ARV. How can that? Yes.
I don't think there's any direct relationship between ARV drugs and glaucoma. Apart from the systemic unwanted effects, I don't know. But if you have any challenge, we advise you see the nearest specialist near you, eye health worker. But ARV versus glaucoma, unless if the person have an underlying glaucoma. But
yes, but I think we also need to remember that the HIV can cause some eye complications that are fairly serious.
Okay.
If the person is having some visual problems, that may be the cause, not the ARVs.
Okay.
And that will need some treatment itself.
Someone, HIV, okay. Okay.
The ARVs, sometimes you have patients coming back with Stevens-Jones syndrome. Once they start...
Systemic.
Yeah, but it has ocular manifestations which the patient goes to the doctor to
first
see.
manifestation in Stevens-Jones is even the systemic skin rash before even the eye itself.
These are effects of ARV on the eye. It's the
Okay,
drug he has taken that brings Stevens-Jones syndrome, which affects the eye.
Okay, straight to the eye as well. Okay. Back to the phones. We have a caller. Abdul from Gombe. Hello, Abdul. Abdul from Gombe, are you still with us?
Hello, sir. I'm hearing you, sir.
Yes.
So my question is, I'm suffering from glaucoma for almost... Hello, sir.
Yes.
Okay, I'm calling from Gombe. My name is Abdul. So I'm suffering from glaucoma for almost since 2000. But I've attended several hospitals in Abuja, Bauchi, but I couldn't get resolved. But there was one hospital that they opened in Gombe, Makkah Clinic. So there was one Pakistan that they brought there. He's a consultant. So at least I've already started seeing him, and he has already given me some Traboten that I should be using. And at least I was being using for quite long, and at least I'm very happy with this. But later on, the organization of the ophthalmologists here in Gombe, they said that the guy is not registered, and they created some kind of this thing, and they pushed the guy out of the country. I think the guy is from Pakistan. So it's like here we doesn't have a kind of... I wanted to ask some of the consultants there, is there any registration that when somebody comes from abroad, he must have to do any registration before he can be able to partake in such kind, at least diagnosis of patients here? Because at least I've enjoyed him, but later on they just push him here in Gombe. So thanks, I'm very grateful. Thanks.
All right, the question will be addressed right away. Yes, Dr. Ghana.
I think, thanks Abdul for that good question. And I'm sure Abdul also will not like people who are not qualified to also treat him or any other person. Nigeria is a sovereign country, and we are also governed by laws and regulations. We have the Medical Council in Nigeria, which governs the practice of all doctors in this country. And likewise, all other countries in the world equally have their own medical council. Even me as a Nigerian, as a physician, just to go to Ghana to practice, I have to be registered to the Ghana Medical Council, even if it's a short-term registration. Ditto for Nigeria. Any physician coming to Nigeria to practice, even if it is on an outreach basis or special mission, such doctors or physicians, actually, by law, they are required to have registration from the Medical Council in Nigeria. You can't imagine somebody just bouncing into Nigeria and start treating patients. What, do you know his background? There are a lot of people who really are not really doctors. They may have just been working with doctors in some hospitals abroad, and they come to Nigeria simply because they are of the other skin, not colored skin, and people assume that they are better than the colored skinned Nigerian doctors. Unfortunately, it is not so. The drug he mentioned, without sounding so harsh on him, Travatan is a common anti-glaucoma drug, and I'm definitely sure at one time or the other, the ophthalmologists they have been seeing, even in FMC Gombe there, where we have ophthalmologists, I'm sure at one time or the other, they give him either Travatan or a similar drug as Travatan. You know, so it's about psychology. I understand his psychology, seeing a Pakistani doctor, you know, but truly it's part of Nigerian law. Anybody coming to Nigeria must be registered, otherwise he cannot practice.
So now that they have pursued the Pakistani
he wasn't pursued. He wasn't pursued.
Well, I'm using his term.
He wasn't pursued.
In quotes. What do you advise Abdul to do since he's a glaucoma patient?
Go to Federal Medical Center, Gombe Ophthalmology Department. They have ophthalmologists there. Okay. Incidentally, a good number of them consultants, excellent doctors are there, whom we train together in Nigeria. Some have even gone abroad for training, and they are back there at FMC Gombe, an excellent facility with all the equipments. Let him go to FMC Gombe. You see the equipments, I know what I'm talking about. So please, Abdul, go to FMC Gombe and you get yourself well taken care of.
All right.
Going to FMC Gombe would be a nice idea. But if you've been to one of those FMCs and see the number of patients the ophthalmologists have to see, it's not very easy. Some hospitals have patients booked for as long as 3 months before they see the consultant. And this is not fair. This is unfair to the patient. There must be something that can be done so that this patient gets attention. And each time I talk from my own point of bias. If an optometrist sees and then picks out the crowd you have in the waiting room is less than a half. But if we keep saying the ophthalmologist sees first, then sends the optometrist, the way it should be. If we have one ophthalmologist seated there, there should be at least 5 or 6 optometrists referring patients to him, and not one ophthalmologist will see 300 patients and then distribute to nurses, to optometrists, and so if we make it this way, the job will be easier for everybody. And when I say that, I am a trained optometrist. I'm a fellow of the Nigeria College of Optometrists. As a matter of fact, a consultant contact lens practitioner. But if you now come in and say, these people are not qualified to do anything, they are not qualified to see the patient, then the clinics will be full all the time. As we finish talking, take a stroll tomorrow. Go to any federal medical center. Go to the ophthalmology unit. And what I'm saying is apparent and clear.
No, I think we have to put this into proper perspective. Yeah. You know, and because this is a direct affront on the government of Nigeria, which I have to defend.
Forgive me if I'm in confrontation,
that's
but
why
that's
I'm
what I
actually
see.
here. You know, the truth of the matter is that everybody in the eye care system, like even the gentleman from the major from Asaba, Delta State mentioned, everybody has his role. Look, in any profession, anywhere in the world, there's a beginning and an end.
Good.
When we say specialist, ophthalmologist has a beginning and an end. Incidentally, ophthalmologist has no end. But now we even have subspecialists. But below that, we equally, like we mentioned earlier, we have other eye care workers. The optometrist that she mentioned, she is one. She said she specializes in contact lenses.
Contact lens
That's very true. That is her job, actually. Optometrists are purely responsible for the issues of problems related to refraction, optics and refraction. Now, if we talk about one ophthalmologist have five optometrists, that is not the issue. In National Eye Center, for example, patients, there are people who actually filter patients. Filtration of patients does not require an ophthalmologist to do. Ophthalmic nurses do that. Optometrists do that.
Okay.
And that's exactly what is happening right now, even in Nigeria. In my clinic, I equally have optometrists working with me. We have no problem. The issue is that
the filtering.
Yes,
the filtration.
Yes,
Yeah.
the filtration has no problem. Anybody can filter and send immediately to the ophthalmologist. As a matter of fact, he's already a glaucoma patient. Only an ophthalmologist can see such patients.
Perhaps
Truly,
we should look at this. If you're having huge number of patients, and I'm assuming that you're having a crowd because you have fewer professionals to deal with these cases. How much more would you require in a country like Nigeria? About, say, how many, specialists in this field would you require us to provide and make a difference into what we're witnessing today?
Yes,
Thank you, Cyril. That's an excellent question. And actually, this is not, and it's actually related to the little argument that occurred just now.
Yeah.
The issue is not only about numbers, and the issue is also about organization and structure of the system. You see, at present, there is a ratio which has been established as the minimum number of ophthalmologists to a population.
And what's that?
Okay. The truth is that I will tell you, but before I tell you, I'm going to tell you that actually I'm moving away from that, and I don't like referring to that because it is somewhat misleading.
Okay.
Okay. And why it is misleading is that technology is moving on, people are sub-specializing, and countries are not the same in terms of population density and access to eye care. So a country like Nigeria, where you have, particularly in the north, where you have relatively large geographic areas and fewer sparser population, you have a challenge of, if you use the same ratio of people of ophthalmologists to the population as you do in, say, Bangladesh, where you're within 2 square kilometers, you have 200,000 people, then you have a problem. So the ratio of 250,000 to a population to an ophthalmologist can be somewhat misleading. So I want us to move slightly away from that. That was used as a minimum standard at a time when Africa had very little. As we're now progressing, we need to start looking away from that number. And what we need to be looking at is, what do we need? What human resources package do we need to make sure people are covered?
Right.
WHO has set up actually a good process and a tool for helping us determine that. So rather than using a simple ratio, I would prefer a facility, a geographic area, a state, takes the WHO tools and says, okay, what is the workload? You put it in. What are my various tiers of what can be treated at this level, and so on, and break down into specific numbers of primary healthcare, eye care workers you need to train, optometrists you need to train, ophthalmologists you need to train, subspecialists, and then you have a more comprehensive figure.
Okay.
So there's a process that can be used, and I would encourage the federal government to work with the state governments as well as local governments to make sure that that happens.
So going by that parameter, we would ask from the National Eye Center, for instance, in Kaduna, what would you require to make that difference?
I think we're still going back to his answer. The tool he talked about is called workload indication for staffing needs. Exactly.
Yes, yeah.
So you identify how much you need to do,
yes,
and which cadre of staff you need to do, and we are working on that with him and WHO office here to actually use this tool to assess the staffing need in my hospital. And I think it will be very interesting, and then maybe from there we'll move on to the states and other parts of the country. But it's sitting down here, it will be very difficult.
Okay.
Yes.
So one thing that we can definitely is definitely clear from many of the discussions that have come about today is that there is no single key to enabling a good healthcare system or access to glaucoma. That's what we are talking about today.
Okay.
We have human resource challenges, both in terms of number, distribution, and
so sometimes you find that even where you have the numbers, it's skewed in such a way that,
yes,
it might not be.
And sometimes it's not easy to, it's not easy because of geography and social things to get everybody. So you need to have a form of task shifting to have the appropriate kind of care at that level that can refer upwards to where the professional is.
And I expect that this situation will be worse in the rural areas, since it's more difficult to get health professionals to go down to that level.
Absolutely.
And I think that's the reason we're empowering the lower cadre of healthcare providers to equip them with these tools at the primary level.
But be that as it may, I think the issue of eye care services should not only be focused on the federal government. I think we must also call on the state. We should encourage the states really to take the bull by the horn. The state government must also recruit eye care personnel, because the patients, after all, are in the state and at the local government. If we wait for Abuja, that is Federal Ministry of Health, to be recruiting, we'll continue to employ and keep them in the National Eye Center, Lagos University Teaching Hospital, Ahmadu Bello University of Port Harcourt. They continue to, the state government have to employ so that they can deploy them to the local government, to the general hospitals, and have them working there. I tell you something, that's serious. Let's take, for example, our hospital in Kaduna, where Dr. Hassan actually is CMD. There's a large number of ophthalmologists, consultants, senior registrars, put them together. Go to Ahmadu Bello Guinness Eye Center, put them together. Go to Kaduna State Government on its own. Go to Kaduna State University Teaching Hospital. They have large numbers of ophthalmologists. Now, how many does Kaduna State have under her employment, under her payroll? Kaduna is well favored. That's not a good example. Let's take Nasarawa State, for example. That's FMC. That's the FMC Federal Medical Center, Kefi. And we have the lateral Arab Specialist Hospital in Lafia. How many, and of all the local governments in the state, for example, how many ophthalmologists do we have outside of Lafia and Kefi? Ditto for many of the states of the Federation in Nigeria. Therefore, the problem actually should go beyond the federal level, down to the state government level. So we encourage the governors, actually that's the only thing we can say, we encourage the governors to recruit eye care workers, from ophthalmologists to optometrists to ophthalmic nurses. They already have nurses in their payroll. They should just send them for additional training, and they'll come back and provide eye care services at the rural areas.
And can I add also that he's absolutely right. We need to make sure that the states also engage actively with eye care and make sure that eye care services are developed both in terms of human resources as well as the policies that will enable the provision of drugs. There are many other things that the federal government can also do, though, in terms of bringing down the cost of healthcare, eye care consumables. I really think things like this, I think the federal government should be aware of something. If they look at what has been published by the WHO and by the World Bank, eye care is one of the most cost-effective public health interventions in the world. And in fact, in terms of productivity, for every unit of money, let's say you spend $1 on eye care, you have a net gain of about $4 in terms of to the economy. So this is a no-brainer for our governments to get involved and actually spend on it. Reduce customs duties on, or even eliminate custom duties on these specific things that will bring down the costs. And also, the necessary finance systems is not all, and I think Nigerians should also be aware of this. The governments cannot do it all alone.
Absolutely.
Both the federal needs to be involved, the states need to be involved, but the communities need to be involved, engaging in social things, social support. Glaucoma is a long-term, we've talked about the long-term issue about glaucoma.
Yeah,
it's so easy, it's so difficult for a person to bear that burden for a lifetime alone. That is why glaucoma groups have been found to be such an effective.
Well, I think importantly, Cyril, maybe I may need to come in here. Well, thanks, Chief Kola, about the issue of government. Now, federal government, right now, the Minister of Health had a meeting with manufacturers in Nigeria, appealing to them to find a way of drastically reducing the cost of medications. They have agreed they are going to work it out. Very soon we shall begin to see a drop in the cost of drugs in Nigeria. Right. That's one. Two, the issue of equipment. Equipment is not something that federal government can say, I'm start giving. Of course, federal government is already funding all the federal tertiary health institutions, by purchase of equipment. But also government is okay encouraging public-private partnership. Already government has created an enabling environment for private sector, particularly the big companies that produce equipment. There's a window that has been created by government now to bring in equipment so that practitioners can actually access. The Central Bank of Nigeria has also kept a huge amount of money for the funding of any practitioner that wants to engage or wants to go into any private practice. So you have opportunity of leasing of those equipment at a very low cost, including the consumables. So really, as a federal government, a lot has been done. That's not to talk about the fact that federal government is one training all the doctors from lower level up to the highest level in the country. Salaries.
Two quick issues. You talked about drugs. Are these drugs manufactured locally, or the bulk of it is brought in?
Bulk is brought in. But we must encourage local production.
So that's another sphere we
have the capacity. The Nigerian government has the capacity. We have the wherewithal. We have the pharmacists, huge number of pharmacists in Nigeria. We have a huge number of chemists. We have the capital. It's all about determination.
Right. And then in terms of personnel, how well are Nigerian universities and institutes doing in the training of professionals in eye care, particularly?
Well, that's one of my primary assignments.
Of course.
Right. Across the board, we train ophthalmologists, we train ophthalmic nurses, we train optometrists, opticians, and these very important community-based health workers, the CHUs, and we have modules for them in eye care, and we're trying, like the CHUs, we train them in thousands. The ophthalmologists, because of the duration, average of 2 or 3, we graduate every year. So we are refining the curriculum so that we make the program more compact and more effective.
And hopefully take in more and do more.
Yes, exactly.
Right.
Yeah.
In training, I think optometrists have trained quite a lot. We have about 6 universities training optometrists in Nigeria. And when you ask about the numbers, we have over 3,000 optometrists in Nigeria. But the sad part of it is that most of the government hospitals don't have optometrists in them. Most of us are in private sector. Like there's a huge employment going on in the FCT now, and I hear there is no need for optometrists in the FCT, and I find that baffling. Sorry I'm hitting these things, but I find it so baffling that there is no need for optometrists in the FCT. Nigeria Optometric Association, be that as it may, we go out all the time to make sure we get avoidable blindness to the best of our capacity. We do outreaches, and when we go to the rural area, even when we go in company of other doctors, the eye unit is always overwhelmed, showing that there is great need. And then the government says there is no need.
Okay.
Dr. Kana. Yes. No. You see, you and I agree that out of 100% of total budget of Federal Ministry of Health, 70 to 80% actually goes on salaries and emoluments.
Okay.
Now, if that is a fact, if that is this is a true statement. Now, you now look, and I just give example, in National Eye Center, for example, how many consultants do you have? What she is referring to really, and which my advice to the Nigerian Optometric Association, don't bother yourself with Federal Ministry of Health. all the hospitals that no, just a minute, let me finish. All the hospitals that Ministry of Health manages are tertiary health institutions. What optometrists are offering, which you alluded to, is primary eye care. Okay. You should focus your employment to the states so that you can get employed into the general hospital.
All right.
Then you can provide.
Yeah. Just one question which I've saved all along, and that's returning to the issue of stigmatization, denial, and all that. And the question is simple. Is glaucoma necessarily a sentence to blindness?
Not.
Maybe we shall.
And I think it's the management of this question that has generated these issues around glaucoma. And because if you mention glaucoma, and an averagely enlightened person will just think the world has ended. Right. It's not a sentence.
Okay.
We have protocols with evidence, and if anybody abide by these protocols and evidence, access, treatment, and follow-up, I think we can keep people sight till they die.
Okay.
Exactly.
Also, let me give one last story.
Right.
I remember a patient I saw sometime in 2004 when I was in Ahmadu University. And when the patient came in, I looked at his record. And he was first seen in that same Guinness Eye Center in AVU in 1975, 1976. Right. He was diagnosed with glaucoma at that time, and I was seeing in 2003. He was still vision. So there is light at the end of the tunnel.
All right, so it is at this point we'll leave it. As I say, no one program can take care of all the issues, but I would like to thank our guest tonight, Dr. Ibrahim Kana, consultant ophthalmologist, Federal Ministry of Health. Thank you for coming. Thank you. Dr. Mahmoud Al-Hassan, Chief Medical Director of the National Eye Center, Kaduna. Thank you for coming.
Thank you very much.
And Dr. Ngozi Nwanikeze, an optometrist, a fellow of the Nigerian College of Optometry. Thanks for being here.
Thank you.
And big thanks also to Dr. Kola Ogundimu, Sight Savers. Thank you for being here. All right. And thank you also to you for being part of this program. Next week we'll reach you again on NTA Tuesday Live. I'm Cyril Stober. Bye for now.